Good morning. Welcome everybody to this first debate organized by the International Psychogeriatric Association, the IPA. The title of this debate is End of Life Care, Multicultural Perspectives. I would like to introduce myself. My name is Edgardo Raif. I'm professor and head of neurology in Buenos Aires, Argentina University, and I serve International Psychogeriatric Association in the Products and Service Committee. We will moderate this session with Professor Raimundo Mateos. Raimundo?
Good morning. My name is Raimundo Mateos, Professor of Psychiatry at the University of Santiago de Compostela. I'm past president of the IPA. I'm very happy to share with my colleague Edgardo this important activity of IPA.
I would like to welcome to the speakers and the audience to share this very interesting and fascinating topic regarding the different points of view and conditions at the end of life and its care according to different cultures and societies. This will be a friendly space in order to listen to different voices, inviting to reflection and to enrich our future attitudes regarding this sensitive and special moment of the life. This is a starting point and is our plan to develop future activities, future meetings, inviting to our panel different experts and religions and cultures in the future, in the next times. And we are open to suggestions for speakers and topics for future debates. Okay, can we start with our first speaker? I would like to introduce Dr. Kai Ito. Following the tradition, ladies first, I would like to present Kai Ito. Dr. Ito is a psychiatrist in Japan. Her research focuses on decision-making in people with severe mental illness. She is currently the director of the research team for human care, long-term care, and end-of-life issues at the Tokyo Metropolitan Institute of Gerontology. She will refer to ethical and sociological aspects related to the end-of-life care issues in Japan. Please, Dr. Ito, we would like to listen to you.
Hello, everyone. I'm very happy to see so many of you here today, and I thank you for giving me this opportunity to present to you. I'm Kai Ito, psychiatrist of Tokyo Metropolitan Institute of Gerontology, Japan. Today, I would like to talk about the ethical and social aspects related to end-of-life care in Japan, especially the issue on decision-making in end-of-life care. For a long time in Japan, caring for older adults was considered to be a family obligation. In Japan, as far back as 7th century, it was stipulated by law that older adults should be cared for by their families. Until the middle of the 20th century, it was a matter of course for older adults to die at home with their families taking care of them. Since the 1950s, death at home gradually decreased and death in hospitals has increased. Now, 3/4 of Japanese die in hospitals with only 10% die at home. This is not because those who are dying want to die in hospitals, but rather as a result of the generalization of leaving end-of-life care to hospitals. There is an interesting result of a national survey on Japanese people's attitudes towards their end-of-life care. One of the questions asked in the survey was where people wanted to end their lives. For this question, 3 different end-of-life scenarios were envisioned, which were terminal stages of cancer, severe chronic heart failure, and progressive dementia. In the terminal stage of cancer, half of the respondents wanted to stay at home. In contrast, In the advanced dementia, 80% of the respondents wanted to be placed in the facility or hospital, while only 15% wanted to stay at home. In the case of chronic heart failure, it was right in the middle. This means that the longer their independence will be impaired, the less likely they are to wish family care. The question here is, why do they make these choices? When choosing where to end their lives, what is most important to Japanese people is that they do not become a burden to their families. This result was striking as people considered not being a burden on their family more important than relief from pain or living with dignity. But here's another question. Have they ever discussed with their families what situations are burdensome for them? There's another interesting study on Japanese people's unique sense of understanding each other without words. 60% of older adults have never discussed their end-of-life wishes with their families. However, 60% of them think that their families know their end-of-life wishes. On the other hand, 80% of children have never heard of their parents' end-of-life wishes. However, 50% of them think they know their parents' end-of-life wishes. Japanese people have these kinds of feeling that people understand them even if they don't say anything. Or like, my mother must be thinking the same thing that I'm thinking. The relationship between the individual and the family in Japanese society differs from that in West, where decision-making autonomy has been achieved on the basis of individualism. Japanese society is a society of interdependence, and the boundary between the will of the individual and the will of the family is very blurred. This blurring of the boundary between the individual's will and the family's will has a significant impact on end-of-life decision-making. Under current Japanese law, no medical procedure or treatment can be implemented without the consent of the patient himself. However, in clinical practice, when a patient's decision-making capacity is impaired, for example, due to dementia, the family's wishes tends to take precedence over the patient's wishes, even if the patient has given advance directive or expressed his or her own wishes. This is quite different from having a surrogate make decisions on behalf of patient. But in recent years, the principle of decision-making autonomy has become more prevalent in Japan. This has caused some confusion among medical professionals as to whether they can continue to treat the family's wishes as the patient's will, which is the traditional decision-making method in Japanese society. Because of this situation, the advanced care planning is getting a lot of attention in Japan, just like in other countries. What is the level of public demand for advanced care planning? 60% of population have thought about their end-of-life care. However, of those, only 3% have discussed it with their families. 60% of people thought it would be better to have a surrogate decision maker. However, only 20% actually designated surrogate decision maker. 60% of the people thought it would be better to create advance directives. But of those, only 8% had actually created advance directives. And to the question, would you like to see a law stipulating that medical procedure or treatment after you lose your decision-making capacity will be implemented in accordance with your advance directives? Only 20% of the people answered yes to this question. So in summary, Japanese people do not discuss their end-of-life wishes with anyone, nor do they create any documentation. Even if they do create advance directives, they do not want them to be effective. So, who decides how? I'm sure that my family will choose what is best for me and for them. In Japanese society, there is such an interdependence between the individual and the family. It is incompatible with the original principle of decision-making autonomy. A major clinical challenge now in Japan, especially in geriatrics, is to consider how decision-making autonomy rooted in the principle of self-determination fits into Japanese culture, and how dealing with this issue can contribute to the well-being of older adults in Japan. Thank you so much for your kind attention.
Thank you very much indeed, Dr. Ito. And we now move to the next speaker, but before that, housekeeping advice. As you know, the session is composed of 4 speakers, and we try to create a very friendly atmosphere. At any time, attendants are allowed and are encouraged to do so, to make any questions using the list of the questions. These will be populated, and the IPA Secretariat help us to that all these questions arrive, and we try that the speakers reply. The speakers are requested to make just very brief introductions, no longer than 10 minutes. So we try to promote that every participant make questions, and we hope for a very active discussion. And now it's my pleasure to introduce to the next speaker, Dr. José Augusto García Navarro is a geriatrician dedicated to the management of health and social care organizations in Spain. He's the director of the Catalan Health and Social Care Consortium, and he serves on the board of directors of the Catalan Health Service. Additionally, he's a university lecturer in the management master's programs at the International University of Catalonia and the University of Barcelona. He's a regular consultant in the implementation of the public health program in several countries of Latin America and the Caribbean region. He currently holds the position of president of the Spanish Society of Geriatrics and Gerontology. And now, José Augusto, the floor is yours.
Thank you very much. First of all, thank you very much for your kindly invitation to participate in this interesting debate. I'm coming here as a representative of the Spanish Society of Geriatrics and Gerontology, not as a general director of a group of hospitals. As you know, Spain is an aged country that continues aging. And in fact, I think that is the 3rd country in the world with the higher life expectancy at birth, after Japan and Switzerland. And also Spain is becoming an ethnically and culturally diverse country with an 11.5, 11.6% of total population foreign. And this proportion will increase during the next 2 decades because we need new people coming to Spain to balance a labor market that is constricting by a low natality. So it is very important how healthcare providers, institutions, but also doctors, nurses, social workers, and other professionals manage this new situation to establish a culturally appropriate and effective care for both for elderly people and also for immigrants. In this context, we need to develop between doctors, nurses, and other health professionals to develop and increase cultural competency. This is a key factor that allows a healthcare provider to know and understand the cultural context of the patient and to avoid stereotyping in the care of a patient. As you know, cultural competency has some key elements as cultural desire, cultural awareness, and so on, to arrive to an endpoint that is cultural encounter. That is the process of obtaining cultural experience through engagement, if possible, immersion in another culture. And it is necessary to be open to learning and understanding the other person's point of view. So we need, at the moment in Spain, to foster cultural competency between healthcare professionals in general and also professionals dedicated to the care of elderly people. In Spain, we have evolved in some cultural factors related to the end of life during the last decades, but also we are observing these cultural factors in other ethnic groups. For instance, in Spain, people in general has progressively learned to face death individually, giving value to autonomy and individuals' right to make one's own decisions about health and dying. But in people with a low cultural level, Spaniards with a low cultural levels, or in immigrants from Latin America, people in general are more likely to consider the family as the decision maker regarding withholding of aggressive treatment, for instance, rather than the patient alone. Also, immigrant patients may come from countries where the physician makes all health care decisions. And patients are unaccustomed to being asked to choose among treatment options. For these people, patient and also family have the expectation that it's the physician's role to decide about end-of-life care. Also, we see in immigrant patients, similarly we saw in Spanish people 50 years ago, different meaning of pain. That's very interesting. No? Pain may be seen as something positive. It's a sign that the body is fighting against the disease towards recovery, or in other cases, a test of one's faith, or even a punishment. In this context, asking for pain medication may be considered a sign of weakness, especially in elderly people. And faith and spirituality can play a significant role in the perception and response to the dying process. And the approximations to faith, religion, and spirituality must be tailored to every culture and religion. It's different in Catholics, Muslim, Buddhists, Jews, and so on. And for a healthcare professional, it's necessary to know the situation and adapt responses to spiritual needs of the patient. Similar situations that need adaptation to different cultures are related to the use of traditional medicine in some cultures, specifically Asian population, and the perception of hospice, palliative care, dying at home, and so on. In this context of aging and transformation of our society to a multicultural society, recently Spain has passed a law to legalize euthanasia, becoming the fourth country in Europe to allow people to end their own life in some circumstances. Spain's lower house of parliament approved the law in March 2021. And the law allows adults with serious and incurable diseases that cause unbearable suffering to choose to end their lives. And this law took effect here in Spain in June 2021. Before this law, helping somebody to die in Spain was potentially punishable by a jail term of up to 10 years. The approval of the euthanasia law was celebrated by right to die campaigners, but condemned by conservative and religious groups. I think that this is the same situation that other countries have faced in the past. Belgium, Luxembourg, the Netherlands, Canada, and Colombia are the only other countries in which euthanasia is currently legal, and also is legal in some states in the United States of America. But not in other countries. This year, Portugal's parliament attempted to take the same step that Spain, but legislation that sought to legalize euthanasia in Portugal was rejected as unconstitutional by the country's top court. So lawmakers from the Spanish parliament, lower house, passed the law with 202 votes in favor, 141 against, and 2 abstentions. In the Spanish society, groups for and groups against the law have demonstrated their positions, and the debate continues at the moment and will continue in the future. In fact, the Spanish law permits 2 voluntary means of allowing a person to end their own life: euthanasia and assisted suicide. Euthanasia is the act of intentionally ending a life to relieve suffering, for example, a lethal injection administered by a doctor. And in cases of assisted suicide, the act is undertaken by the person themselves with help. So this is the context in Spain and the debate around end of life care, an aging population, a multicultural transformation of our society, and in the middle, a new law of euthanasia that is in the debate of society every day. We can talk about these issues during the debate. Thank you very much.
Thank you very much for your words, Dr. Garcia Navarro. It's a fascinating topic. And now it's my pleasure to introduce the next speaker, is Rabbi Mario Roisman. Rabbi Roisman is the senior rabbi at Beth Torah congregation in Miami, Florida. He received his BA in Jewish philosophy and his master in education from the Hebrew University in Jerusalem. Additionally, he was appointed as Doctor Honoris Causa by the Jewish Theological Seminary of America in New York, celebrating his over 25 years of serving in the conservative movement. He will talk about ethical and religious aspects related to the end-of-life care issues from the Jewish perspective. This is your words. Thank you, Rabbi Rothman. Could you listen to me, Dr. Roisman? Okay, in the meanwhile, we are okay.
Can you hear me now? Can you hear me now?
Yes, Dr. Roisman, we can hear you with a little noise.
Now is better?
Absolutely better, yes.
So I apologize. I guess I'm responsible for eating. So thank you for the opportunity. I feel honored now listening to my colleagues. I mentioned that I will bring the Jewish opinion. So I will start with the famous joke that two Jews, three opinions. Sometimes two Jews, three opinions sometimes may sound cynical, but it's not. Let me say, what does it mean, two Jews, three opinions? It means that if A has an opinion and B challenges him, maybe A can change his opinion. So if B has an opinion and A challenge him saying, hey, you are right, but not completely right, so B may change the opinion. So what's the new opinion? The third opinion, which is a better statement than the one presented by A, a better statement presented by B, and now we have option C. What I'm telling you the following, because like my colleague from Japan explained what's going on in Japan, our friend from Spain explained what's going on in Spain, I will not speak about the country. I will speak about a civilization that is 3,000 years old and is evolving permanently. So as a rabbi for 33 years, I will love to begin, and I will not pass my 10 minutes, saying the following. I'm very inspired by an article from a nurse that accompanied dying people for many, many, many years. And she did the research, no? Dr. Kae Ito spoke about a question that people ask themselves and families, and sometimes the question they don't ask themselves. So let me tell you what she found about what are the 5 regrets of people who are dying. And the reason I'm starting with that, because when we have this kind of panels and we speak theoretically, no we, because we are very sensitive people, thus chosen to speak, but sometimes I see colleagues and past myself, coming and seeing he's dying. When I see a person dying, I see his history, I see his finished business, his unfinished business. So let me go to what she finds are the top 5 regrets of the person who is dying, so we can understand how to approach them. The first one is, I wish I had the courage to live a life true to myself, not the life that others expected of me. Why I'm so interested in this statement? Because if people didn't have the courage to live in the life they wanted, maybe they should have the courage, and we should help them to die in the way they want. Second regret, I wish I didn't work so hard. This came specifically more for male patients because they miss their children's youth and the partner's companionship. Women also spoke of this regret, but as most were from an older generation, many of the female patients had not been breadwinners. Third, I wish I had the courage to express my feelings. Many people suppress their feelings in order to keep peace with others. The fourth, I wish I had stayed in touch with my friends, and people regret not doing that. And the fifth, I wish that I had let myself be happier. And this is surprisingly common because many did not realize that the end happiness is a choice. Having introduced it, let me go straight to our topic. It's a mitzvah. It's a Jewish precept. Yes, we have 613 commandments to help those we care about die through the holistic and sensitive approach of hospice care. Once it's fruitless to look for a cure, the focus shifts to provide the best possible care to the person or family, helping them whatever time they have left in the richest possible way. Hospice does not have to be a particular place with a certain number of doctors or nurses or team or healthcare providers. It's more a philosophy of care. And often it becomes an enriching experience for the family of the dying patient. When we are sitting by the bedside of the dying, we don't do it because we expect to get some blessing. but many report that amidst the sadness, they find in themselves tremendous holiness and devotion and courage, working itself out to be a tremendous blessing. 33 years ago, when I became a rabbi, I had a harder time choosing hospice care than do other religious and ethnic groups. A remarkable percentage of Jewish families know that Jewish tradition values life above all, and that one must fight for life at all costs. I know why. It starts with the master story of the Jewish people. Abraham is told to sacrifice his son Isaac to show his faith. And God says, don't do that. Don't kill. Death is not the program. So Jews for centuries placed tremendous importance on survival and continuity, and therefore they will refuse to see death as anything other than an enemy. I have seen many a person struggling in the last days and weeks of life to maintain that fierce determination to defeat death that seems, as it were, to be written in the collective. I saw a transformation. It's more life. There is evidence in Jewish texts that mortality is part of God's creation and inevitably presence that no one will escape. While certainly there are times in our life when we have like to pretend it isn't so, sooner or later we have to meet death in the face. A profound sense of preciousness of life naturally arises when the time remaining is short. There's great wisdom to be learned from turning around to face what we most fear. Now, let me just give you a very brief explanation how we rule when it comes to rule in Jewish life. The second most important book in Jewish life is called the Talmud. It was written between the years 0 and 500, and it's a discussion among rabbis. Now, you can't expect them to speak about feeding tubes 2,000 years ago and to speak about ventilators. But they have examples which are the master example for us to learn. Let me give an example. They tell us about a rabbi who was dying, Yehuda the prince, the crown of his generation. And the students are praying for him to continue alive. The servant, the maid, makes noise to interrupt that prayer. And he died. And the Talmud give her the right. She said she was right. She stopped an agony in the rabbi's life. Now, do you want to say that this is euthanasia? No, it's not, because euthanasia in Jewish life is prohibited. But this is the parallel of using something that in their conception, it was prayer, to stop that so he can live with dignity. I give you another example. The Talmud says about a story when somebody was breathing very heavily, and they realized that every breath came at the same pace that somebody that was chopping wood, and this helped him breathe. So they go and they say to the person, stop doing that. And the person died. Now, the Talmud discusses and says, this is permitted, but if the person dying will say, move me from a room, this is forbidden. What's the difference? In one, you stop something that was causing the life, which is almost the near death, to happen. In the other one, you're doing something actively. Just to let you know, and to use language in our days, and we saw it a lot, unfortunately, in COVID times, ventilators. No? In Jewish tradition, like I say, to Jews, many opinions, but that's why, let me just, for those who are not very familiar with Judaism, we have three main groups in Jewish life in our days: conservative Jews, Reformed Jews, and Orthodox Jews. And we all have our courts of ruling law. I represent the one in the middle, which is the conservative. For example, we debate a lot about ventilators. Now, for some people, once you connect into a ventilator, then you cannot disconnect it. Why? Because it belongs to the function of the lungs. But the truth is that if you look a bit deeper and you are the doctors, the physician, at the end of the day with a ventilator, what you're doing is you are not allowing the natural course of the body to end in the way it was created by the creator. So you will find opinions about the most extreme to the right saying a ventilator can never be disconnected. And those will say, you gave him a chance with a ventilator. The doctors are telling you it will never work again. So you can't disconnect that because it's not natural in his body. I hope I was able to show at least where the Jewish tradition takes the sources to rule in our days. And this is a continued conversation in the rabbinic courts, because as we learn more about feeding tubes and we learn more about a different way to prolong life, we need to have fierce debate. But just to be clear, euthanasia will be considered murder, not to apply a medical treatment because we see he's dying, is an act of mercy. Thank you.
Thank you very much indeed, Rabbi Mario Rothman. And now it's my pleasure to introduce to the next speaker, Dr. Devanjan Banerjee. Dr. Devanjan Banerjee is a geriatric psychiatrist from India and life fellow, Indian Psychiatry Society. Recently, he's associate editor of Aging Psychiatry Frontiers and chief coordinator, Journal of Psychosexual Health. Dr. Banerjee works in the area of human rights and dignity-based mental health care of all the adults, medical misinformation, stigma, social psychiatry, and qualitative research. He's an advocate for healthy aging, mental health equality, and zero diversity. And Dr. Banerjee, the floor is yours.
Thanks, Dr. Matthias. I thank the IPA and the moderators for having me here. And I thank my co-panelists for the wonderful insights. I hope I'm clear, right? My audio is clear, right?
Yes, I can hear you, can listen to you very well.
Right, thank you. So welcome all. I put forth my perspectives as a caregiver today and also a psychiatrist, so I will not be totally unbiased. There are very few areas of interest which cut across so many domains like end-of-life care, and of course, as a component of it, assisted death or euthanasia, whichever way you look at it. These intersections are so numerous that it's extremely difficult to take any one particular side on the issue. I don't know at the end of whatever I present from an Indian perspective, whether you'll be more confused or whether we'll be aligned on one side. To start off, since the very advent of civilization, an eternal question has troubled humankind and also has been the basic facet of many religions. To whom does your life belong to? Yourself, your loved ones, the state, religion or the Almighty based on your faith, etc. Let me start by mentioning something that I had faced. When I was midway through my medical residency, you know, a time when people, especially your family, has already started considering you as a physician and you feel so proud and happy about it. My granddad went into ventilatory care after a sudden kidney shutdown on the backdrop of many medical issues and dementia. Needless to say, I was very attached to him, and that time far away from home. So after nearly 2 weeks of fruitless efforts and financial drainage, my family looked up to me to know what my decision was in continuation of ventilatory care. Days were passing, we didn't get much response. Numerous questions plagued me. Guess today's debate started long back then itself in my thoughts. I debated with myself. Is this what my granddad wanted, lying in a hospital bed with tubes? Won't he get better? Is this the end? Will I be responsible for ending his life with a wrong call? Should I prolong his life at least by a few weeks so that I can get back and meet him for one last time? Or did I really want to see a person who was always so active in my mind, with good memories, with tubes in and out of his body in a so-called vegetative state? Emotions versus logic, medicine versus morality, understanding versus empathy, hope versus reality, religious and ethnic beliefs versus truth check. These were the debates that were running in my mind. Expert opinions, internet scrolls, medical texts, nothing helped me, while my family, again, considering me to be an expert, waited for my final verdict. After 3 days of sleepless nights and chaotic days just before my exams, I had a lengthy discussion with the doctor. The ventilatory care was stepped down. Granddad left us within a few hours later. Till date, a part of me assures that I have relieved a very healthy and always young at heart person of a long, painful, unidirectional struggle against death, while a part wakes me up many nights, cursing me for ending a premature life, which, who knows, may be prolonged. Today, when I talk about this after hearing to all my co-presenters, it looks like I have gone back to that day, standing on the jigsaw of intersections related to end-of-life care, finding which path to take or choose. Now, here I should caution that when we talk about, and we are talking about end-of-life care, it does not encompass just the decision of assisted or non-assisted death or euthanasia. It includes all domains of living, including physical, emotional, spiritual. It extends to the caregivers and family even after the death of the patient in question. And it also brings to us the concept of good death, the very meaning of the word euthanasia, which means death with dignity and in and around familiar places and people. Now, when we talk about euthanasia, which is a very common and a debatable issue, of course, there are multiple components to it. A person in question, a person or a physician who has the onus of it, his or her advance directives and the voluntary nature of his or her will. Am I deciding it on my own, or am I in a state to decide it, which will, of course, be in neurocognitive disorders like dementia? A causal proximity. Is there a terminal illness which may lead to, my death? Actions that can lead to the outcome of death and the outcome itself. Now, the onus and the voluntary nature of the will of the person in concern are of paramount importance to me as a physician. To give you an example, in Hinduism, my religion, at the time of near death in any terminal illness, the person is made to lie down comfortably in the presence of his or her loved ones, given sips of water if they're able to swallow. His or her favorite music is played, and tulsi plant leaves, which are considered to be auspicious, are arranged near their head. This ritual is considered to be helpful for both the person and family accepting death. In fact, in the Vedas, which are the Hinduism texts, the religious texts, and in different mythological stories and characters, life is divided into 4 stages, with the last stage being called Vanaprastha, or living in the forest, which actually transits to accepting aging and accepting death with dignity. This renunciation and acceptance of the inevitable, and nothing can be more inevitable than death, forms a large part of navigating the process of death with self-dignity, which is kind of a hallmark of Eastern traditions. In today's world, where healthcare is so much rights-based, and we all know the different rights convention, the arguments in the favor of assisted death may be respect for one's autonomy, equality, delaying unnecessary suffering, compassion, and transparency in the process of treatment. In most nations, basic human rights include right to life, but does it include a right to die is the question. I, as in my practice, have seen that most Indians are reluctant to seek passive euthanasia because killing oneself is equated with suicide. Of course, we did not have legal provisions for the same till very late, which I'll come to later. the religious connotations. Many people, especially in terminal illness, are afraid that they may not be able to end their lives, and very importantly, possible complications if the attempt fails. Now, as a medical personnel, what do I do in my regular practice? I, of course, assess for the capacity, whether there is any undue influence. And in a country with more than 1,000 ethnic groups like India, it's a Herculean task. You know, we in Indians, we always like to debate, and end of life is like a hot cake on the plate. Article 21 of the Constitution of India states that no person shall be deprived of his life or personal liberty except according to procedure established by law. Many Supreme Court and High Court cases have considered this Article 21 to be both for right to life and right to die. However, till 2017, the Indian Penal Code considered any act which hastened death to be an act of abetment of suicide or homicide. With rising concerns about human rights, a euthanasia regulation bill in 2002 suggested compassionate termination of life of persons completely and permanently invalid or bedridden by the incurable disease. And there were regular discussions between the law commissions. The landmark case of Ms. Aruna Shanbag, who stayed in a persistent vegetative state for 42 years before dying of 2015 due to pneumonia, made the change, the landmark paradigm change. Even though multiple appeals of passive euthanasia were rejected, finally, the prime debate was between the acceptance of death as an automatic form of destiny versus the violation of right to live with dignity. A 5-judge bench Supreme Court judged for legalization of passive euthanasia. However, there was not much said for living wills or advance directives, and physician-assisted death in active form is still illegal. Now, these are abstract concepts and often considered politically contentious in India because it can spark millions of social, cultural, and religious dilemmas, as we have many subgroups. The Mental Health Care Act, which was a very, very different paradigm shift in 2017, is a marker for the United Nations Convention for Rights of Persons with Disabilities. However, it does not really include the end-of-life decision-making in dementia. And this ambiguity makes different physicians confused as to whether they really need to come forward together. We have discussed multiple times in the Indian Psychiatric Society, if a neutral physician can be brought forth, a psychiatrist and a neurologist can be brought in, especially with end-of-life care and dementia decisions, but multiple challenges have been noticed in the drafting, implementation of advanced care directives, level of clinicians, patients, caregivers, judicial and administrative bodies, also the medical training, the years of medical training, and there is a distinct difference of opinion in the percentage of physicians involved, their specialty, their own moral beliefs, their religion, and the public. Another facet is family value in Indian society. They're collectivistic, they promote interdependence, cooperation, and social cohesion. This family considered a very important source of social support when you're doing end-of-life decision-making. Not needless to say, I should put forth my point that lengthening living without meeting needs may lead to several psychosocial issues, including worsening of the clinical condition of the person, caregiver burnout, abuse, poor living condition, high financial burden, and loss of self, autonomy, and dignity of the person, which is so very much involved. I would believe that a collaborative effort of all disciplines concerning in end-of-life care is very much important, and we need to involve caregivers, health professionals, lawyers, and care organizations with a clear-cut guideline in India as to some form of legal framework for the physicians and the law personnel alike. I often wonder if we rephrase death as passed away at peace, resting in peace, no more expired, will these terms make any difference of our acceptance of end-of-life decisions? I leave the decision to you. However, it is imperative to start a collaborative dialogue with people living with terminal care, dementia, their caregivers, palliative care experts, and palliative care needs to be the standard and should be involved in a multidisciplinary team. Opinions will vary and debates will be endless, but taking time and considering the voices and values involved will clarify those puzzled intersections that I stood as a medical resident deciding for or against to continue the life of my granddad once. And we all need to remember that there is always a choice. Awareness campaigns and support groups for caregivers need to be actively promoted by all forms of organizations. And here comes the role of such important role of such debates. I would end by saying this, that this debate is endless. There will be continuing discussion, debate, and discourse on the ethical and legal validity of assisted death, euthanasia, or end-of-life care. But in truth, end-of-life care is much beyond. And in a country like India, it is not just about the right to live or die. In a world where health has moved towards human rights and social justice, it's about improving the end-of-life quality in all people, respecting their values, respecting their choices, autonomy, and dignity. Thanks for letting me put my views. Thank you.
Thank you very much, Dr. Banerjee, for your words. Of course, there are universal principles, but in other societies and cultures, it could be different ones, and that's the reason for our debate. Thank you for all luxury panel of speakers, and I would like to make an open question now. There is perhaps a new term coined, it's MAID. MAID means medical assistance in dying. And the question for every integrant of the panel is MAID-assisted or assisted suicide or euthanasia appropriate for other persons with mental health conditions or psychosocial disability? It's an open question for anyone.
I think that it's a very difficult question, this question. But to choose your future, I think that you have to be fully aware and conscious when you make this decision. And so it's very difficult to make this decision if you have a cognitive impairment or a mental disorder, an important mental disorder. So I think that it's better not to make this decision in this condition, in this situation.
Dr. Banerjee?
Yeah, thanks, Dr. Raik. I think, yeah, as Dr. Rose mentioned, that this indeed is a difficult question to answer in one word. But I would say that in whatever individuals we have seen, and with the discussion that we have had with families, at least in my country, I think a big challenge comes when the person does not have a clear advance directives and is not in a state to provide the will. So either severe mental disorders or dementia, and I would say not all dementias, but again, in moderate and severe dementias, because capacity is a continuum. So the advance directives of the person, if there is any legal provisions, involvement of a neutral physician, ruling out undue influence, and especially whether the will to die from the person is voluntary and the person has the capacity to give it, will be of prime consideration from the role of a physician's case. That would be my point. But that shouldn't mean unnecessary prolongation of suffering for a person.
And in this case, to establish advanced care planning is very, very important to make it in the early stages of the disease only, I think.
Thank you.
Any other speakers like to provide an answer, or can I ask, make a question? Please turn on the microphone, Rabbi Mario Rosman.
I say you can go ahead with the next question, because it's a very painful question, and we are not here to answer likely question. But I also saw my mom died from dementia, and I saw her deteriorating, and I understand it's a burden to the system. I understand it's burden economically. I don't want to take it lightly. I just saw beauty in her to the last breath. So I think this is the debate that it's coming. No.
Yeah. I fully agree. I have a question to Dr. Ito. I think I have I'm sorry, I'm not sure if you can hear me. Can you hear me?
No, now.
Yes, now.
Now, so I should repeat the question. Why don't Japanese people discuss the important issue of end-of-life care wishes with their families?
That's a question for me?
Yeah.
Thank you.
Japanese. I'm very curious about other cultures. So.
Maybe for one reason, since kindergarten, we have been taught that we shouldn't bother others and that being assertive is selfish. And the purpose of being able to take care of oneself is not for independence itself, but for not bothering others. And I think there is a sense of Japanese culture that order or harmony in group is more important than the will of the individual. And one of the Confucian teaching is following your children when you're old. And we no longer learn Confucianism in school, but I think Japanese people still have the sense that this is an order of the family. That's my answer.
Thank you very much.
I'm
not sure if, please.
No, I was thinking the following, because I think this is so interesting, no? Because when will I have the chance to listen to somebody so brilliant from India, from Japan, and from Spain, if it wasn't for what your organization is doing? But I have the feeling that with internet and with going to be exposed to different cultures, and I may be wrong, because who am I to speak about Japan? But I imagine that the next generation of Japanese people, when they will see what's going on in the world, the next generation of Jews, when they will see what's going on in the world, the next generation of people from Spain and from India, I think this topic will be evolving quicker than we think. Even if with my little knowledge about Japan, and I know how traditional, let me give you an example. Sorry for this may be joking, but there is a very well-known play in Broadway called The Fiddler on the Roof. It's about a father with 7 daughters, and he only wants the 7 to marry Jews, and one goes out of the faith, etc. It's amazing. So one day they went to Japan, and they performed, and the Japanese people said to the Jewish actors, "How do you know us so well? This is exactly what we..." So the Japanese were convinced that this was written for Japan. So we have so much in common, and at the same time, I think that what's coming in the next 50, 60, 70 years, if not earlier, will be like culture-oriented. But wow, maybe what's going on in Spain can help my culture to be shaped in a different... I think this is where we are going, I think.
Absolutely agree, Dr. Roisman. The perhaps we can say between branches, the globalization of some new knowledges perhaps will change a little bit our mind or our own traditions. In the meanwhile, I will invite to any attendants or assistants to make his questions, suggestions to the panel. We have a luxury panel. And I have now a question for Dr. Banerjee. Dr. Banerjee, India is a very special country in terms of large population and tradition of perhaps reincarnation, a lot of religions, a lot of varieties. How is considered for the Indian religion or for the Indian tradition the idea for assisted in dying. I mean,
Yeah.
in terms, sorry, I try to clear my question in terms of the possibility of soul transmission or reincarnation.
Yeah, thanks, Dr. Raik. I think that's a very, very pertinent point because, again, so we have different religions, and there are Hindus, Muslims, Buddhists. In fact, even as I was mentioning, even in Hinduism or in Muslims or in Christianity or in Buddhism, we have different subgroups and we have racial, ethnic peculiarities among each. So when we talk about reincarnation, a majority of the mythological stories, texts, religion, in Hinduism, they believe in reincarnation. And it's also related to how a person dies and how peacefully, quote unquote, a person dies. What circumstances the person dies, as I was describing, that the circumstances are made familiar. Sometimes even a priest is called, and the person is told to be there with the person when he or she is dying. So I think these play a very important role in whether the person or the family wants assisted death or not. And as I would like to resonate this, that like Dr. To was mentioning, in Japan, there are some ethnicities, especially from northeastern and from the north of India, who believe that it's important that you have to undergo and navigate the pain if you have to have a peaceful death experience. If it is cut short, then probably you may not be reincarnated the way you want it to be, or the forms of reincarnation will be degraded. Now, how we look at it, whether we look at it in a religious angle or with a different lens, with a sociological perspective, that is totally different. But when we discussed with the law commissions and with the government from the Indian Psychiatric Society, the first argument that we brought forth was, irrespective of the cultural and the religious framework, there should be some direction towards the physicians as to what they can offer. Because now, even when the IPS conducted its survey, a lot of the physicians, almost more than 2/3, I would say, they were not even aware that the Supreme Court had actually favored passive euthanasia. But then it varies from case to case. And as Dr. Jose was mentioning about advanced directives, advanced care planning, it's also important that when we talk to somebody with terminal care as a psychiatrist or as any other specialty, we take into account his or her religious beliefs, what he or she thinks about death, how they picture death, what they think their after the death experiences or ideas of reincarnation will be as per their religion. Like, it's as important as when we do a mental status or a physical examination, because these pointers will help us go into a dialogue with the person about end of life care. And that's what I think you started by mentioning, that it's a process and it's not a 1 day or a 2 day thing.
Fascinating. Thank you very much, Dr. Banerjee.
I would like to make a friendly reminder to all the audience that they are encouraged to send in questions, because I think we have not received yet questions. And also speakers can make questions. Yeah. So I have a general question from your perspective, from your country, from your society, from your philosophical, religious position, from whatever point you like to answer. What do you think, what you consider are the key elements you need to know to deliver a good end-of-life care to elderly people? It's an open question to all of you.
Sorry, Dr. Matthias, if you don't mind, can you just repeat the question? I think internet glitch, I didn't get it fully.
Okay, so from your perspective, you are talking here from any perspective you like. cultural, religious, country, society. What are the key elements you need to know to deliver a good end-of-life care to all people? I think Jose likes to answer. Please turn on the microphone. Jose Augusto, please turn on the microphone.
Okay. Now,
Okay.
I think that as has said Dr. Banerjee, and also has mentioned also Rabbi Mario Rothman, I think that end-of-life care means more than treating physical symptoms, and it is necessary to consider also psychosocial, existential, and spiritual aspects for patient needs in general, and tailored to a patient in particular. And of course, you need to know how to make a good palliative care to relieve physical symptoms. This is evident. But also you, as a provider of healthcare, you need to consider the patient and family's perspective on death and dying, the patient and family's perspective on health and suffering also, and the perspective on hospice and palliative care services use. That is very important in some cultures, and the patient and family's acceptance of Western medicine here in Spain, in the case of Asian population or immigrants, and the use of traditional practices. And also it's important to consider the role of spiritual and religious beliefs and practice and elements of communication that is really important in situation of end of life. I mean, how patient and family communicate, and if necessary, you have to allocate interpreted services to allow this communication. And of course, I think that it's very important to take into account and question the patient what's their role, their own role in the process of decision making.
Yes,
Beautiful
please go
answer.
ahead.
I will. Can I say something?
Yes, please, Rabbi Mario.
I was thinking, I heard Dr. Ito from Japan saying that since kindergarten, and I want to be sure I understood correctly, a Japanese person is taught not to be a burden to the family, correct? She said that, yes? Yes?
Yes.
That's an amazing statement. It's an amazing statement, and you know, it gives me chills when I hear that because it's so beautiful. At the same time, it's so beautiful. So I need to take my mileages, and when COVID is over, to go to Japan and learn more. It's amazing. In Jews, you know, it's a little bit different. You know, every Jewish mother thinks that she has the right to bother their children. Now, Dr. Rachel, the question is the following: what do I need to serve better my people? I need organizations like yours to lobby so we start teaching death in our elementary and high schools. How come the kids can play with the computer and with the phone at the age of 5, 6, and we decided that they are geniuses because of that, but they have no clue what death means. I'm not saying to prepare them at the age of 6 or 16 that they will die, but I'm saying there is no way you can go out from a university and not being exposed to the topic, the sociological, psychological, medical language, because at the end of the day, it will be you. It may be your parents first. That's the ideal in every family prefers the elderly to die first, but it can be each of us. And we allow the educational system in every place in the world, not to touch in something this is so obvious that we will die. So this would be very helpful if organizations like you can lobby So the curriculum should include, no? And then we can give them, India thinks this, Japan thinks this, Jews think that, Christianity doesn't matter. Before we go there, how to approach death in general.
Please, Lebanjan.
Yeah, I think that's a very, very pertinent point Rabbi Mario had made, because I was just about to come to that. I have a couple of points to make in continuation. So one is, at least COVID has taught us that, especially when the second wave ravaged India and many other countries, that death is not something which you can really always prepare for. So at least in my country, what I've seen, that the fear of death and the fear of anything related to death, which is again a perpetuated form of ageism, prevents people from entering into a discussion about death. In fact, at many places, death is considered to be a very taboo topic. So even when physicians understand that, we need to engage or involve in dialogue related to end of life, it is sometimes postponed to such an extent that not only is it traumatic for the person who is in question, but also for the family, because as I mentioned, that end of life care does not stop with the outcome, which is death. It goes beyond. It's also for the family to understand how I have seen, the respective family member in his or her last days. The second, that we at least, working with the IPS dialogue that I was mentioning, what we learned is it's a very important need to bring in these concepts in the early years of medical training, MBBS, irrespective of which specialty branches out after that. Because when we have a team, when we have a multidisciplinary team to decide on end of life care, it involves different specialties. And in a country like ours, which has, a 1:1 lakh doctor-patient ratio, we do not have the luxury of always bringing in specialists. So understanding or appreciating, and I'm glad that as, my speakers were mentioning, co-panelists were mentioning that this discussion has a lot to do. I think discussions and dialogues like this will encourage younger minds, and especially in people with not only medicine, I would tell people in sociology, anthropology, psychology, other allied fields, and even the general public, to come out of that phase where we think about death as a taboo topic. Yeah, of course, none of us in our senses would want to end our life, but it's imperative that we understand that if we have to start a dialogue about end of life care, we have to start it now for a person who is terminally ill. And on that particular day when I plan to wean him or her out of ventilated care, I have learned that lesson, unfortunately, with my personal experience, but I would wish all others to start it much earlier before that final day comes. That would be my take.
Okay. Thank you, Benji. I have a question for Rabbi Roisman. Rabbi Roisman, comparing the diverse religions, at least the monotheism ones, the concepts are similar, are diverging, there are differences or coincidences. This would like you heard.
Okay, I will answer. Thank you. Thank you, Doctor, for the question. I will not take up on me representation of other religious, but I will tell you the following. If a religion, for example, like Christianity, stresses the idea of the resurrection as so big, the approach to death will be different. I have no doubt. If Judaism insists that what happened when you die is mystery, the approach to death will be different. I am clear. That's why from the pulpit, upon the pulpit in a church, you will hear more and the resurrection, thanks to the Son who resurrected. And in synagogues, we don't know, because when Jacob the patriarch was dying, the Bible says, come, what will happen with me when I die? And then he remained silent. What's the message? We don't know. I have the feeling that we are more similar in this case, this is for the headlines in the newspaper, to the Muslim religion. Even if the Muslim religion, I don't know if like in India, they have 1,000 differences, but they have a lot, more than even in Judaism. So what I try to say is your master stories will determine the way you see death. So if the Son of God died but resurrected, and we don't have a Son of God, we have God who is eternal and nobody resurrected, so we will see it different. I hope I answer your question.
Absolutely, absolutely. Thank you, Rabbi Reisman. May I have a question for Dr. Cayito? Kai, we would like to know which are the current status of palliative care for older people in Japan.
Sorry, one more time, please.
Yes, I will repeat for it. What is the current status of palliative care for older people, the older old specialists in a country that has a very traditional longevity? What happens with the palliative care for older people in Japan?
Thank you for your question. Japanese people like to see doctors, and the number of hospital visits per person per year is about 3 times that of United States. And since there's no system of family physician, GP, patients can decide which hospital they want to see. So in general, Japanese people like large acute care hospitals such as university hospitals, and they're like specialists, not general physicians. And it is the same for older adults, so many of them still seek for acute care by specialists at the age of 80. So the psychological conflict of shifting to palliative care are great, not only among doctors, but also among patients who also fails to make the shift to palliative care. I think that's the situation.
Thank you. Thank you. May I have another question for Dr. Garcia Navarro? Jose Augusto, I was amazed when I listened to the notice of the approval of the euthanasia law in Spain, because Spain is a country with a very strong Catholic tradition. I suppose that it was very hard to approve it. Can you please tell us something about the relation between the Catholic Church and the new approval law?
Well, Catholic Church is fighting against the euthanasia law. At the moment, the society, in Spanish society, we've got half of the society that is in favor of the law, and 50% that is no is against the law. And we think, I think that this situation will continue in the future. And also, we have important problems to the implementation of the law, because I think there's the two main problems to implement the law here in Spain are doctors, and also administration. Doctors, because we've got a lot of them that have become objectors. I mean, they do not want to apply the law because of ethical or religious reasons. Catholic reasons, but in most cases, personal reasons. They do not consider euthanasia as a medical treatment, but an imposition from the parliament. And this situation has produced a scarcity of doctors willing to practice euthanasia in some regions of the country. This is an important problem for the implementation of the law here in Spain. And also administration. Administration has been very, very, very slow in the development of some elements of the law, as the commissions that guarantee that people demanding euthanasia are capable. I mean, people are fully aware and conscious, and commissions that supervise the process. General law in Spain is a federal regulation that affects all of the country. But the implementation of the law, as example, the commissions that guarantee the implementation, is a responsibility of the regions. And we have observed a different speed between these regions to implement the law. And this is so important for the discussion of the law at the moment in Spain.
Thank you, Jose Augusto. Thank you very much. Perhaps inside the panel, there is any question for any other of the panelists? Otherwise, I have another question to Dr. Cayito. I have information that the traditional family values in Japan are still very strong, and that sometimes the people couldn't decide by self some important decisions, as like the way to death. Could you please tell us something about it, Kai?
Thank you for another question. Again, I think Confucianism has a big influence to us. Confucianism was introduced to Japan around 6th century, and it is an ideological philosophy for politicians to realize their ideal politics and making nation, as you know. And in the Edo period, which is 17th century to middle of 19th century, it was regarded as the spirit of samurai, and through kabuki and other performance, it spread to common people as something very cool. And the Confucianism teaches obey your parents, obey your eldest brother, protect women and children when you become the patriarch, and obey your children when you're old. And these teachings were used to avoid causing conflict within the family. And with the family as the smallest unit, the similar hierarchy was created to bind the community together, and further hierarchies were created to maintain order in the nation. So the Japanese followed this method of governance without much resistance. And I think this means that the Japanese people have accepted society in which the will of family is more important than the opinion of the individual, and the order of the community is more important than the situation of the family. And since Japan hasn't experienced many invasions by other countries or conflicts between the ethnic groups within the country, we Japanese may have little sense that our rights will be violated if we do not decide for ourselves. I think this is the background.
Thank you very much. If there are no more questions, we are approaching.
No questions from the audience yet. So I would like just to make a clear comment of intentions, because there is a question, the last question, to any one of you. Does social stigma or perspective of dementia affect end-of-life care received compared to other terminal conditions? Is there any specificity from your point of view? This is an open question to all of you.
May I, Dr. Matheos?
Yeah, of course.
Yeah. So just keep it brief so that others can also pitch in. I think it's a very important question, and at least speaking from India, I can say that how we perceive a person, an individual living with dementia, and the caregiver burden, especially with families who are not socioeconomically that great, single caregiver families, makes a huge difference to deciding for end-of-life care. And not only that, I would extend that besides social stigma, it's also about understanding what are the social policies and what are the provisions available. If you're not aware of that, alongside stigma, it can play a major role in deciding for end-of-life care. And especially caregivers' perspectives on the relationships, how the person's relationship has been before the dementia started, and throughout the person living with dementia. They become very important when we have seen in clinical practice when people ask for end-of-life care.
Thank you. I think Jose Augusto like also to.
Yes, I think that. Thank you for your question. I think that is very important. Yes, I think as Dr. Banerjee that there are some characteristics for palliative care or for end-of-life care in general for patients with dementia, specifically for patients with dementia. The first is the terminal stage is often defined by a set of symptoms in general, as inability to eat orally, or weight loss, or lack of mobility, and so on, with a very, 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 very difficult estimation of the lifespan in every individual. And this is a characteristic specifically for people with dementia. So you have the responsibility to start the situation years before the end-of-life situation will arrive. And this is very, very, very important. Also, I think that caregivers must be involved in all decision-making processes and must understand evolution of the disease, problems during this evolution, as infections, falls, delirium. So it's very important to establish a good communication between professionals and caregivers. And also, psychological support is very, very important for caregivers to express and manage their feelings, depression, guilt, frustration, loss, and other feelings. And you need specifically for this population, dementia in the end-of-life stage, you need to have a good training of nursing and auxiliary staff in hospitals, also in nursing homes, and also in domiciliary care, specifically for palliative care for people with dementia.
We have also received a related question. In these situations, you think what kind of care you think it's really more important, the provided by professionals or the provided by family?
I will answer in the way the Jewish law asks the question. The question is the following. It says, respect and honor your father and your mother. It never says love them, correct? Because nobody can tell you to love somebody. But respect is respect. So it is one of the commandments. So the Jewish law will ask the following. Let's say my mother has dementia and she needs full care. What is it more proper for a dignity? For me to give her a shower and see her naked, or for me to pay somebody to do that job? So the question is, who has the responsibility? Me directly with my hands and my time, or I can buy that? And I think that's a dilemma, and every family answers the way they can. Obviously, me as a male decided not to bathe my mom. I had a great sister, and she did that. I did other things that I felt more comfortable doing. But I think that Jewish law, which I don't believe that I don't believe that we are the owners of truth. I'm just bringing my truth, no? For me to be right, you don't need to be wrong, no? I mean, to Hinduism and to Confucianism and to Islam and to Christianity, I'm not the owner of truth. But Judaism presents both views. Respect dad and mom. and you will determine in which way it works. If it's for you renting that program, or it's you involving yourself with your body. And when people come to the rabbi, because the rabbis are not priests, we are teachers and judges, I will always do and suggest people to do both, to decide in what they get involved, and this is your duty. You don't give up, and this is what you pay others to do because they can do it better.
Very quickly, Dr. Mateos.
Okay, go ahead.
I agree with this opinion. I agree with this opinion. The question is formal or informal care for elderly people in the end of life stage. Both. In Europe, 50% is provided by informal care and 50% by formal care, and it's necessary to interact from the 2 points of view.
Yeah, I personally fully agree with this. The next question is how to do it, but this can be for the next session. Edgardo, if you let me say something and you close the session, I would like to make a very clear definition of intention that probably should be done at the beginning. With this activity, IPA, we made a lot of discussions how to do it. We were fully aware how big task was to devote a little time to this topic. And I think the best way to say what were our intentions is with in the Spanish culture, the appetizer. I don't know if in other cultures, but appetizers in Spanish culture, you eat something to increase the appetite, to eat the real food. And I hope everybody enjoy this as appetizer. And IPA in the next future will organize a lot of activities, a lot of more information with a lot of more different speakers from different cultural religions and activities and professions all around the world to lead with this very, very complex topic. And just once again, I really like to thank our speakers and the IPA Secretariat for the wonderful job. And I let my colleague Edgardo to close the session.
Thank you very much, Raimundo. Raimundo and myself, we hope that you enjoyed this debate. This is just, as you say, an appetizer, an introductory debate, and we hope to see you again in future meetings of this kind. Thank you very much, and we wish you a wonderful day.